Delighted to be here at this meeting of the Pakistan Society of Internal Medicine, particularly because this is the first annual meeting since the Pakistan Society joined the International Society. And I hope that this will be the beginning of a long and mutually beneficial partnership between the two societies. As you heard, I'm talking on COPD today. And you might wonder why, because in 2003 the new gold guidelines were published, and this is an excellent document. So what have I got to say in addition to that? Well, there are a few parts of this document that would justify emphasis. There are some parts which, perhaps like this page here, which are perhaps a little bit complicated, unnecessarily so. And there are some aspects of the guidelines that perhaps need a little interpretation before they can be applied in the clinic. So I'm going to focus on four aspects of COPD. First of all, to say something about the genesis of COPD, to talk about the importance of non-pharmacologic therapy, to give you an overview of bronchodilator therapy, and then to talk a little bit about the controversial area in terms of the role of inhaled corticosteroids in the management of COPD. This slide shows the development of lung function throughout the lifespan. There is a rapid increase in lung volumes during late childhood and adolescence associated with physical growth. Lung function then plateaus between the ages of about 18 and 25, a little earlier in females, and then there is a gradual decline in lung function throughout life. The traditional model of the development of COPD is that in patients who are smokers or exposed to biomass smoke, there is an accelerated decline in lung function, leading to marked impairment of lung function and consequent disability and death. As a result of epidemiologic studies, it's now clear that quite a proportion of patients who subsequently develop COPD do not achieve maximal lung function in early adulthood. And this is as a result of insults occurring early in life. And in these patients, the usual decline in lung function, or only a mildly accelerated decline in lung function, can lead to the development of disability and death. This concept is reflected in this table out of the GOLD guidelines, in which the importance of early life events, including premature birth and low birth weight, are emphasised, and also chronic airways disease in childhood, the importance of chronic asthma in children. For the first time in this guideline, vaping and e-cigarettes are listed as etiologic factors in the development of COPD. Our management aims in COPD are symptom reduction, with an improvement in exercise tolerance and improvement in health status, and then reducing adverse outcomes, exacerbations, reducing disease progression, and reducing mortality. No treatment achieves all of these aims, and in fact some of these aims are achieved only by a very limited number of interventions. I'm going to now talk a little bit about non-pharmacologic management for several reasons. First of all, such therapy is underused, particularly in primary care, but paradoxically, it's the non-pharmacologic interventions that have the greatest impact. Smoking cessation, I think, is obvious, and it is the only intervention shown to show the rate of decline of FEV1 in COPD. Influenza vaccination is of proven benefit and is cost effective. There is less evidence supporting the use of pneumococcal vaccination, but it is nevertheless generally recommended. Long-term oxygen therapy has until recently been the only therapy shown to reduce mortality, but of course it is only in those with severe hypoxemia, and there is good evidence that long-term oxygen therapy does not have a survival benefit in those with moderate hypoxemia. Remember that in COPD, dyspnea is predominantly due to mechanical factors, and very little is due to, in fact, hypoxemia, and it is the overwhelming evidence suggests that supplemental oxygen therapy does not reduce dyspnea in COPD. Pulmonary rehabilitation, the major component of which is exercise, demonstrates the largest improvements in exercise capacity and quality of life. Pulmonary rehabilitation after hospitalisation is estimated to have savings of around $6,000 for patients over their lifetime. A number of years ago, we demonstrated that pulmonary rehabilitation can in fact be successfully initiated during the last day or so of hospitalisation and continued thereafter, producing similar benefits to that when patients are recruited as outpatients. It is estimated that more than $1 billion of potential savings could occur in the US if all patients who were eligible for pulmonary rehabilitation were able to undertake such treatment. However, it was greatly underused, and there are a number of factors for this. One being the lack of access to pulmonary rehabilitation programs, and secondly, the non-referral by physicians and family doctors to this potentially very important and very beneficial therapy. This slide I've entitled Bang for Your Buck in COPD Management. Underneath the water is the importance of factors to prevent COPD development, but you can see that above the water the most important factors are smoking cessation, influenza vaccination and pulmonary rehabilitation, and only as we get towards the top of this triangle do drug therapies seem to feature. The initial drug therapy, moving now on to drugs of course, the initial therapy in COPD management is with bronchodilators. And I have tried to summarise an enormous amount of data on this one slide based on Cochrane reviews and various review articles. The first is that long-acting antimuscarinics in this situation are better than short-acting antimuscarinics. For all intents and purposes, all the long-acting beta agonists are the same, and all the long-acting antimuscarinics are approximately equal. In COPD, the LAMAs are approximately as effective as the LABAs. There is possibly some evidence to suggest that LAMAs are better at preventing exacerbations. But there is no doubt that the combination is better than one form of drug or the others. In COPD, the evidence suggests that LAMAs plus LABAs are probably better than long-acting beta agonists plus inhaled corticosteroids. And we'll touch on this in a moment, but it is perhaps that triple therapy, long-acting antimuscarinics, long-acting beta agonists plus inhaled corticosteroids may be better than any two, at least in terms of preventing exacerbations. Now, so how do we go about this? So in the clinic, we trial one drug or another and we assess the response in terms that are meaningful to the patient. I use spirometry in the diagnosis of COPD, but I don't use spirometry in assessing the response to therapy. I assess that in terms of the patient's change in their exercise capacity and their functional capacity. I get them to tell me about some form of exertion that they do on a regular basis, and I ask them to establish a baseline and then see if there is a significant change as a result of adding this therapy. So I assess the response. Other factors to consider when you're thinking about, well, which LAMA or LABA will I use? Well, some can be used twice, some are used twice a day and some are used once daily. But at least in respiratory medicine, I don't know of any studies that have shown that once daily therapy is associated with better adherence than twice daily therapy. There's also the importance of the preparation and delivery system. If you use a PMDI, do you need a spacer? Is the device easy to use? Are you going to use the same or different devices for different forms of drug therapy? Or can the drugs be combined in a single device? In practice, what do? I show all the devices to the patient and let them play with the devices for a while, and for them then to decide which they think is most likely to suit their needs. A few other things to say in relation to bronchodilator therapy. To state the blindingly obvious, COPD is not asthma. And in this condition, there does not seem to be a risk of unopposed long-acting beta agonists, that is, without inhaled corticosteroids. And there's pretty good evidence now, quite a lot of evidence, to say that beta blocker use either for management of hypertension or heart disease is not contraindicated in COPD. There is probably, and we're going to talk about this again in a moment, there's probably no good indication for the widespread use of inhaled corticosteroids in COPD. Data suggests that up to 80% of patients in the UK and the US with COPD are on inhaled corticosteroids. Remember that inhaled corticosteroids are not benign. They are associated with adverse effects, specifically an increased risk of pneumonia. And as we heard yesterday, following an episode of pneumonia, the mortality is increased for at least 1 year due to cardiovascular causes, probably in relation to the pro-inflammatory state that follows that episode of pneumonia. Also, patients who are elderly and with comorbidities have a poor outlook when it comes to acute pneumonia. We know that if patients are on inhaled corticosteroids, these can be safely withdrawn. However, it is likely that there is a subgroup of patients who are likely to benefit from inhaled corticosteroids. So let's turn now to the gold recommendations, and I'm just going to focus on this phrase that is in bold. So for patients who have more than one exacerbation or more a year, and a peripheral blood eosinophil count of more than 300 indicates patients who are more likely to respond to a long-acting beta agonist inhaled corticosteroid therapy. Now, initially this recommendation was based on post hoc analyses of randomised controlled trials, usually with a dichotomization of the eosinophil count, showing those with the higher eosinophil count seem to respond better to inhaled corticosteroids than those with the lower eosinophil count. This is the impact study in COPD that compared triple therapy with two forms of double therapy, a long-acting beta agonist and an inhaled corticosteroid, and a long-acting beta agonist and a long-acting antimuscarinic. And it showed that the rates of exacerbation, which was the primary outcome in this study, were lower with the triple therapy than with double therapy. Now, there are issues related to this study, and I'd be happy to talk about those in the discussion. But this study, one of the aims of this study was also to look at the relationship between peripheral blood eosinophil count and response to steroids. And that is summarised on this slide here. You can see that those who were on inhaled corticosteroids, the pink group and the blue group, there is the rate of acute exacerbations showed very little change with the change in with increasing eosinophil count. However, in those not on inhaled corticosteroids, the green band, there was an increasing rate of exacerbations with increasing peripheral blood eosinophil count. And you notice that the sort of crossover here, where the two sets of curves seem to diverge, is around a peripheral blood eosinophil count of 200 to 300. However, there are issues with using an absolute cutoff of peripheral blood eosinophils. I mean, if we're going to use this as a biomarker, then we need to consider the fact that there's an inherent variability in the peripheral blood eosinophil count. There's even a diurnal variation in the peripheral blood eosinophil count. And that the relationship, as we have seen on that last slide, the relationship between peripheral blood eosinophils and reduction in exacerbations is a continuum. And it's not adequately described by dichotomising the peripheral blood eosinophil count. And to me, it seems biologically implausible that there's some magic number that predicts response to inhaled corticosteroids. And so we shouldn't focus on a dichotomy. These cut points are a guide at best. And we need to consider other factors that may predict the response to inhaled corticosteroids. And perhaps our approach should be something like this, which I hope incorporates research evidence along with clinical expertise and incorporates patient values. So we look at the peripheral blood eosinophil count. If it's low, then these patients are unlikely to respond to inhaled corticosteroids, and our focus in management should be on the LABA plus LAMA combination. If they have moderate eosinophil count, greater than 200 or 300, and remember, the higher the eosinophil count, the more likely they are to respond or benefit from inhaled corticosteroids. We consider other factors that might indicate a benefit. There is evidence from other trials that those with high rates of acute exacerbations are those who seem to benefit most from inhaled corticosteroids. Some of these patients do have a history of asthma and may have previously benefited from inhaled corticosteroids, and that was applicable to a substantial number of people recruited into the IMPACT trial. On the opposite side, we need to involve our patients in the discussion that these drugs do have adverse effects, and there are patients who may suffer harm as a result. Certainly those who have risks of pneumonia or recurrent pneumonias, we would, excuse me, certainly need to think long and hard about the use of inhaled corticosteroids. We need to know that there is evidence that inhaled corticosteroids does influence immune surveillance at airway level, and that there is an increased risk of non-tuberculous mycobacterial infection, and even some evidence of an increased risk of tuberculosis infection. And there are risks of other side effects. Elderly people get a lot of skin thinning and bruisability with inhaled corticosteroids, even at conventional doses. So I'm suggesting that this is perhaps an approach that we might take in deciding whether or not we should be starting a patient on inhaled corticosteroids. So I have talked to you about the importance of early childhood insults and the fact that this may lead to a failure to achieve maximal lung function in early adulthood, and that therefore we need to think about the mechanisms of development of COPD that's much wider than cigarette smoking. I've tried to emphasise the fact that non-pharmacologic management had the greatest impact, and that bronchodilator therapy remains the basis of pharmacologic management, usually with a combination of a LABA and a LABA combination, and that there is a limited role for inhaled corticosteroids. And before I step off the podium, I'm going to remind you that in late October, early November, the World Congress of Internal Medicine will take place in Prague in the Czech Republic, and I hope that some of you will be able to join us in the beautiful city of Prague, and I know that Professor Richard Checker has a fantastic academic program. Thank you very much.